Hello, and welcome to the Global Tracheostomy Collaborative 6th Annual International Symposium. This is the parent breakout session. My name is Emily Keevan, and I am a tracheostomy program coordinator, a respiratory therapist by background at Children's Mercy, Kansas City in Missouri, the United States. So a little bit about our institution is that we're kind of located right in the middle of the United States. We are a nonprofit pediatric center, and we were founded in 1897. We have 8,400 employees. We're a 386 bed institution with 57 PICU beds and 84 NICU beds. We're kind of located right in the middle of the Midwest, covering half of Missouri and all of Kansas as a pediatric institution. We are one of the only 10 centers in the nation to be verified as a Level 1 Children's Surgery Center by the American College of Surgeons. And we are exclusively pediatric focused, with every surgery attended by a board-certified pediatric anesthesiologist. Our tracheostomy care, we place about an average of 35 trachs per year. We have an established tracheostomy program that includes a medical director, a manager, program coordinator, educator, and family support. We have a comprehensive education program for families, providers, and the community. We have a multidisciplinary inpatient team that does weekly rounds. We have an infant and pediatric trach clinic, trach vent clinic for our infants up to the age of 2, and then for our peds patients 2 and older. We also have pediatric home care services with in-home respiratory therapy services. So today we're going to share a little bit about our Parent and Family Advisory Council and a little bit about the creation and the need for that. We're going to talk a little bit about the role and the impact for our families, a little bit more about our Patient and Family Advisory Council. Is that we were established May 5th of 2017 is when we started. We meet once a month. We have an average of 12 to 15 members, and our PFAC is what we call it, leads hospital initiatives. They created the Family Day, which I will show you a little video of here in just a minute. They initiated and led a family support group, which that support group meets twice a month. And then it's co-chaired by a parent on staff. So part of our tracheostomy program is that we feel strongly in the patient and family voice, and so we have a parent on staff. That parent on staff is Kylie McElroy, and she is here with us in this presentation. She's been on staff for a little around 2 years now. She was on our Parent Family Advisory Council before that. And she has a son, Parker, who had a trach for about 3 years, and that's Parker there. So we're going to hear from some people, various people, providers, family members throughout this presentation. And they're going to kind of give us their perspective on the patient and family voice. And so next I'm going to play a little from Kylie, telling us why the patient or the parent on staff role is so important. Hi, Kylie. Thank you so much for coming on to share today. Would you be willing to share your story with us and why you believe having a parent on staff is so important in ensuring the patient voice is heard?
Yes. Hi, Emily. Thank you so much for having me. So Parker is our son. He's 9. He was born in 2012 and received a tracheostomy about a month before we went home. Fast forward of a few years of isolation and depression, Parker was decannulated, and then not long after, I was asked to join the family board at Children's Mercy, and I did, hoping that it gave me like an avenue or just a resource of someone who understood. So I did that for a few years, and then there became a spot on staff available, and I applied, and so 2 years later, here I am. I think it's really important that the parents' voice is heard within Children's Mercy's walls, because our children are, they're children in their lives, and it's not a textbook, and they're not, they're not, no one's the same. They all have their own stories, and they all are their own person. And so giving parents that insight so that our voices and concerns and even like accomplishments are heard, and not just the statistics on the paper, or this is what is supposed to happen and it didn't. So I just think it's really nice for us to be able to have that voice and to be able to give back.
Yeah, thank you so much for sharing, and thank you so much for being part of our team.
Thank you.
Okay, so. Okay, so next I'm going to share with you the voice of another one of our parents from our Patient Family Advisory Council. Her name is Maggie Carnes. She lives in the Kansas City area. She had a son, Logan, who had a trach in 2016 and has since passed away. She's married and has a 4-year-old daughter, Helen, and she helped to found the tracheostomy PFAC in 2017. And we're going to hear from her why the PFAC was, why it was so important for her to be part of the PFAC and to create the PFAC, because when she went through the tracheostomy, there was not those resources for her. So we're going to hear a little bit from her. Hi, Maggie. So thank you so much for joining us today and for being an integral part in the creation of the Tracheostomy Patient and Family Advisory Council. Would you be willing to share some of your story and why the creation of the PFAC was so important to you?
Yes, so I joined because my son Logan had a trach. He was trached at 9 months old. I joined after he had passed, but it was important to me to be a part of PFAC and to spread awareness and to share his story, because I wanted to still make a difference and to be a part of Children's Mercy and to give back, because Children's Mercy had given so much to my son, and they had helped our family so much, and I just wanted to be a part of that, and I wanted to be able to give back and help other families as much as possible, and use the knowledge that I had on trachs to be able to help other families, to help them, because it's overwhelming when you first come home and you have a little one, and it's a lot to take in. So if I was able to help, some other families, then I wanted to be able to. So
yeah. Thank you so much for sharing and for being part of our PFAC, and for being willing to share with us today.
of course, I'm really happy to be a part of it.
Okay, great. So we heard from Maggie kind of why it was important for her to be involved, even though her son had passed away. And Jennifer has a little bit of a different story in that she lives in the Belton, Missouri area. She's been in the Mercy or Children's Mercy Network for 21 years, as she has 4 boys, 2 that have spina bifida, and her youngest son, Joseph, has a tracheostomy as a result. She also helped found the PFAC in 2017, and she is an incredibly strong leader in patient advocacy. She's been to the Capitol with us, advocating for stronger nursing pay, and speaking with senators and Congress at the state level to improve their pay, thus increasing nursing staffing for the state of Missouri. And that photo there is actually the governor of Missouri, Governor Parsons. So that photo was taken with when we went down to advocate. That was the second time we had gone. The prior time we had gone with Joseph, he actually, when we were in one of the senator's offices, he took his trach out. And his nurse was there, which was great because she was able to quick put the trach back in and kind of share with the senator in that moment why it's so important to have that nursing and to have trained caregivers. And he was able to, in real time, show the importance of having that extra set of hands. So she's going to talk about why having that patient voice is so important, not only within your hospital or within your institution, but also within your government.
Hi, Jennifer. Thank you so much for being a parent within our Patient and Family Advisory Council and agreeing to meet with me today. You and your son Joseph have been an integral part in advocacy, not only at Children's Mercy, but also at the Missouri state level. Would you mind sharing with us from your point of view what the impact of the PFAC and advocacy work meant for you and your family?
Sure. Thanks, Emily. So I have 2 sons who are disabled, and so advocacy started for me 21 years ago when my now adult son Jonathan was born with spina bifida, and I just felt alone, and I knew that there was other parents out there who felt the same. And so with the help of Carol Haithman, who is a former nurse at Children's Mercy, we started a spina bifida parents support group, and we used to meet at Children's Mercy. So that was kind of my first step into advocacy, putting together the meetings and meeting with the other parents. And from there, I went on to serve on the Spina Bifida of Kansas City board. I was the secretary for a couple of terms, and I really always felt advocacy was very important in school, in the medical world. And so I took it upon myself to just find out everything I could about everything with Jonathan, with spina bifida. And then I had Joseph. A little later in life, I had Joseph, who also has spina bifida. And while I felt very confident in the spina bifida world, with Joseph, he came with a tracheostomy, and he has paralyzed vocal cords, and he also has central apnea. So he also came home with a ventilator. And that was a whole new life for us. I often refer to it as spina bifida on steroids. So what I had to do was relearn everything I thought I knew. And what I found in the process was that there were, I was fortunate to find the answers, and we were fortunate with our home health nursing. We always had hours covered. We were in a very fortunate position. But what I found out is a lot of people aren't, and they, through no fault of their own, they have trouble finding the answers. They have, there's a block between communicating with the parents and the doctors or the hospital or even our state legislatures. And And so I thought, well, here we are, we're in a very fortunate position, and I can find these answers. And what I wanted to do was to advocate for everyone who couldn't, while I was advocating for our family and Joseph. So I was fortunate to be asked to be part of the Parent Family Advisory Council for the tracheostomy program, and I jumped on it because I hadn't really been a part of a organization in a while, and I kind of, it was new, it was it was brand new, and I was super excited because I love to have that communication with everyone at the hospital, and I just felt like what a great opportunity. And there were several things, I think for children who are on ventilators, we have to stay in the NICU, and so we had a meeting where we were able to advocate for our needs as a family who has to stay, or not the NICU, I'm sorry, but the PICU. And we had to advocate, for our needs. What these families needed is so much different than what a typical PICU patient would need from the staff and the doctors. And so we had a fantastic meeting, which still I talk about just constantly because it went so well. And our voices were really well heard. And as you mentioned, I went to the state capitol a couple of times when the funding in Medicaid was cut for home health nurses, and a lot of families were affected by that. And as I stated before, we were very lucky with our hours not being cut, and we always had coverage, but a lot of people don't. And it was hard. It's hard for those families, and especially with the cuts. And I just felt it was important for Joseph. And one time Jonathan went with us also, just to show our family. We brought our nurses with us. And it was just great to be in front of the state senators and representatives and let them see what a special needs family looks like, why the nursing is so important. And so, so that was pretty special. And I anytime I can go back, I absolutely, would and will. But I just think for me at this point, of course, advocating for my son is, number one, as it is with all parents. But, again, I'm just so fortunate to be able to help others see our life and to see others, what other people, how their lives may look and how they may look different than ours, and why they need my voice out there speaking along with so many other families.
Yeah, and we really, really appreciate your voice and spending time with you at the Capitol. I've personally gotten to do that with Joseph, and so we thank you so much for your time and for sharing with us today, and for letting us know what advocacy means to you and your family.
Oh, thank you. Thanks, Emily.
Great. So Jennifer kind of shared with us her story and advocacy and why that patient voice was so important to her. And the advocacy channel that she went through was the creation of our Patient and Family Advisory Council. With that council, we went as a team to the Capitol and advocated for the increase in nursing pay. So at Children's Mercy, we actually kind of sit on the state line, and so we have patients that are within the state of Kansas as well as within the state of Missouri. And Kathy Keck is another one of our Patient and Family Advisory Council members. She joined a little bit later, but she actually had already been advocating prior to joining the PFAC in the state of Kansas, advocating for her daughter. And so that is really important to her too, to advocate not only at the state level, but she wanted to advocate then within the hospital system too. So we're gonna hear from her. She is from the Topeka, Kansas area. She has a husband who's a nurse practitioner for adults with complex medical needs. She, as I was saying, she's an incredibly strong leader in advocacy, has 5 kiddos, 2 that are adopted, 3 with special needs, and 2 of them have complex medical needs. Her daughter, Maria, has a tracheostomy. We're going to hear from her a little bit more about her story and her story of advocacy within the state of Kansas.
Hi, Kathy. Thank you so much for being a parent within our Patient and Family Advisory Council and agreeing to meet with me today. You and your daughter Maria have been an integral part in advocacy not only at Children's Mercy, but also within Kansas. Would you mind sharing with us from your point of view what the impact of the PFAC and advocacy work means to you and your family?
Thanks, Emily. Well, I think having a voice is so critical for our kids that are complex, both medically and developmentally, because otherwise they don't have a voice, right? And so being that strong voice for them can mean all the world. So with my daughter Maria, being a voice to ensure that we got a law change to make sure that there was some justice that would happen. My daughter was shaken at 7 weeks old. And in Kansas, our laws were really lenient on a perpetrator that would cause that kind of harm to a child. And so we were able to, use our voices and make some changes at the state level to create a law that would change the penalty for what's called shaken baby syndrome in Kansas. And so now somebody no longer can get probation for doing such a horrific thing. So I think that's one, making sure that there's justice for kids that have trachs as a result of abuse. And, also advocating at the state level, because now that she has the trach, she requires 24-hour nursing service, right? But in our state, I don't know about other states, but in our state, the nursing pay for nurses is really low. So being able to advocate and talk to the legislatures about having a competitive rate so that we actually can get nurses in our home to help support our family. Maria is the youngest of 5 kids. And so there's other things going on around here too, and life gets pretty busy. So having that additional support to support her needs and also allows her to be more part of her community and just do things that my other kids are able to do because I have an extra set of hands to help us do that, and making sure that those rates get increased. And then at the local level, I think I've had experience in 2 ways. One as a foster parent and then one as an adoptive parent. And what I know that is that as an adoptive parent, my voice is much louder and much more receptive, just because as a foster parent, sometimes your voice is limited. So having experienced kind of a limited voice and now like a full parent voice, I think, it's just so important to be able to talk to our providers and even, make some recommendations of changes to help that for other foster families to make sure that their voices do get heard even if they're not an adoptive family yet, or even if that's not their plan, because at the end of the day, we're taking care of some pretty complex kids 24/7, and we know them better than anybody, and being able to be their voice when they can't, I think is pretty a critical thing. And I didn't know about the PFAC when my daughter was in foster care. And so I was sad that I missed that opportunity to connect with other families. But now I'm so glad that I do know about it and I can help other families and help, be a resource to others going through the journey.
Yeah. Awesome. Thank you so much, Kathy, for sharing. We definitely find your voice to be, an invaluable part of Children's Mercy. And so we thank you for speaking up and for being part of our PFAC.
Thanks.
Great. So we've heard from our family members why that having that voice is so important, and really we can't move forward comprehensively without that patient voice. We need them to kind of circle back to and make sure that what we're doing is actually helpful, and that what we're doing is meaningful to them. And so one of our social workers, Kirsten Hudson, she's been a social worker for 23 years, 20 years at Children's Mercy. She is primarily within the ICN and is one of our critical care team leaders. She's co-leader of the Tracheostomy Family Support Group that meets twice a month, which was a PFAC-led initiative. And she's a strong advocate in the state of Missouri as well, going to the Capitol to advocate for that stronger nursing. And so she's going to kind of give us a little bit from her perspective why having that patient voice within your institution is so important.
Hi, Kirsten. Thank you so much for meeting with me today. As a social worker at Children's Mercy, you get a firsthand view of the amount of support that our tracheostomy families need in bringing home their medically complex children. Would you be willing to share what the impact of the Patient and Family Advisory Council's initiative for the Family Chat Support Group has meant to you, or has meant to our families from your point of view?
Sure, I'd be happy to. Thanks, Emily. The Parent Family Advisory Council is just key to so many of our parents that are going through the process, because they get to then sort of connect and meet with other families that have been through it and are surviving at home. And I think so many people are excited but very anxious when it is finally time to go home. And so to have chats, to have, emailing, calling, things like that to bounce ideas off of, and just to have that support has really been imperative through this whole process. I mean, even small things like, how would you set, your room up at home for your baby? Or how do you stack all of the medical equipment? Things like that. It's just nice to be able to share that. And, for staff, we're not physically in the home all the time. And so just the support that comes from that has been really wonderful for our families.
Awesome. Thank you so much for sharing, Kirsten. Your work with our families has been invaluable.
Thank you.
Okay. So Kirsten kind of shared with us why having that parent-family support group is important, and it's important not only to the families, but it's important to the staff too. And Dejo Miller is going to share with us. Her history is in 2004, her daughter was diagnosed with cancer and spent 300 days inpatient, receiving a bone marrow transplant at that time. In 2008, she started as a parent on staff at Children's Mercy and has been here now 13 years and is a patient and family engagement program manager. She has an associate's in early childhood education and development, a bachelor's in management and human relations, and a certificate in pediatric bioethics. She's going to share with us a little bit why the patient voice is so integral to the healthcare institution and why we cannot move forward without having that patient voice, weaved really well within our system.
Good morning. Dejo, thank you for taking time to meet with me this morning. You are an essential part of ensuring that the patient voice is heard here at Children's Mercy. And one way in which you have achieved that was through the creation of the Patient and Family Advisory Councils. We have heard from our families what the council means to them and why it's so important to take into consideration the voice of the parent when making decisions. As the mother of a patient who is now a staff member, could you share with us the impact the PFACs have on our staff and bedside team?
Sure, I'm happy to share. These PFACs have really made such an impact on Children's Mercy and really changed our culture in how we provide care. And the impact on the staff, one of the big things is that meeting with families and having this voice be such an important part of how we provide care helps staff members connect to purpose. It helps those that are providing bedside care and those even away from the bedside have that direct connection to why you're here. And that brings meaning back to a lot of staff that can get caught up in the routines of the tasks at hand and always focusing on what's not working well and always looking at those solutions. Meeting with families and having these PFACs available gives staff this connection to why they're here, why they chose to do what they're doing. Families help remind staff of what's going well. So you keep doing that. You don't need to fix everything. There's a lot that's going well. So the PFACs provide that opportunity to know and understand what's working well. They're also very honest and help us understand what's not going well, what's not working for families. For families, healthcare doesn't just happen inside a hospital, inside a clinic room. It happens at home. There's impacts outside of their visit with the hospital, and they bring light to that. So then staff can help identify what matters to families very easily. They're accessible on a regular basis for families to share that information. In the PFAC, there's this mutual learning that goes on. So the families learn from the staff members that are leading that PFAC what the barriers are on the hospital side. And the staff learn what the barriers are for the families. So together you can collaboratively come up with a better solution, a quicker solution. You get to that end sooner. It saves on resources for staff. They don't work through a whole project only to have it not matter to families or not work for families. Doing it together, you're going to get to a better outcome faster. And I always like to remind everyone, and this is what our staff have learned, that you have a multidisciplinary team at the table. You have to make sure that you have those with the highest stakes in the game present. They're going to remind you why you're doing it. They're going to help you get to your outcomes faster. And that's what we've learned at Children's Mercy, and why our PFACs are so robust, and all the way up to our CEO. They're listened to and heard, and have had a really strong impact.
Awesome. Thank you so much for sharing, Tijo. The PFACs have definitely been an invaluable resource here at Mercy.
Okay, I'm going to play a little video clip here of I spoke that we have a family day, and this is a feature on the news. And one of our kids that was at Family Day kind of sums this all up the best as to the voice.
The moment you walk in the door, this house becomes, if home is where the heart is, then wherever you may go, the moment you walk in the door.
We'll just mute the ad here for a second, but the little kiddo in this section kind of sums up best the importance of the patient voice. Oh.
You weren't expecting the Hulk to look like this. Hopefully we'll see him here in a second. We will show you, though, some other superheroes. They are wearing something called tracheostomy tubes, or trachs for short. It does help patients breathe. Today was Children's Mercy Hospital's Trach Family Day, and for kids like John, it was a chance just to be a kid.
It's pretty cool because they don't really ask questions because they know what it is. And so it's not as uncomfortable to talk to them as it is like normal people.
Many kids who have trachs were born early. A lot of them have underdeveloped lungs. Some will outgrow the need for a trach, and others will have it for life.
So as one of our PFAC-led initiatives was to have this family day that allowed them to just be themselves, to be a kid. And so that it was designed around kids with tracheostomies. And so that is something we did twice, and then we had a pandemic. And so we hope to resume again after the pandemic. So I have a stop here to answer any questions that may be in the chat. And then I'm going to switch gears here just a little bit. So now we're going to switch gears here a little bit and talk just a bit about the patient and family-centered collaborative care, the importance of the multidisciplinary collaboration, not only in the clinic setting, but through transition from pediatric to adult care. We recognize that this symposium is not just about pediatrics, but is about, is international, so it's pediatric and adult trachs. We also think, though, that the creation of a PFAC in the adult institutions would be incredibly valuable as well if your institution doesn't already have an avenue for sharing your patient voice. So my first speaker for transitioning from pediatric to adult care is Jill Nussbaum. She's been an RN for 10 years, 8 years care at Mercy. She has a master's in early childhood education, and she's the co-founder of the Pediatric Trach and Home Ventilation Clinic. Her current role is the clinical coordinator for the Pediatric Trach and Home Vent program, and she's going to talk to us a little bit about that transition and the importance of it being a collaboration with the patient.
Jill, thank you for agreeing to share with us today. You are the Pediatric Home Ventilation Coordinator here at Mercy, and we're an integral part in starting the Pediatric Trach Vent Multidisciplinary Clinic. Would you be willing to share why you felt that creating the clinic was such an imperative part of improving the patient and family experience?
Sure. Thanks for having me. For many years here at Children's Mercy, we've had an infant home ventilator program for infants who are tracheostomy and ventilator dependent. Neonatologists have managed those patients while they're in our hospital and then continue to follow up with them and provide primary care when they're discharged from the hospital. They partnered with ENT and pulmonology, and they attended the clinic visits there in the infant home vent program. However, when those children were between 2 and 4 years of age, they needed to transition out of the infant program. They would find a new primary care provider who's able to see older kids, and then all of the specialists they would have to see separately. So that's including ENT and pulmonology. Our families gave us some feedback and made it clear that this was a difficult transition, a difficult time of life for them, and they had to find all of these specialists where it had been handled in one place before. And so these kids are growing really quickly at that age. They're working on important milestones regarding their trach and ventilator, and progress was slowed when they had to wait between ENT appointment and then for that doctor to pass messages on to the next provider, and then they would wait to see the next doctor, and then messages would get passed back. So it just really felt like it was slowing things down at a time when their kids were growing really fast. Our ENT, pulmonology, respiratory therapy, and speech therapy came together and decided to provide a clinic to coordinate care more efficiently and make decisions in a more timely manner for these kiddos. We work together with their PCPs and other specialists, and many of the kids that come into our clinic from infant home vent are working towards decannulation and will be with us for a long time or for a short time. And then we also have a large number of patients who will remain tracheostomy and vent dependent for their lifetime. And so there's a lot of time left at Children's Mercy after the age of that transition of 3 to 4, and we wanted to make that time more satisfying for the patients and families and a little smoother for them.
Yeah, thank you. With that transition, then there comes another transition, and at Mercy, our true north is the patient and family experience. As a pediatric facility, eventually our patients transition to adult care. Can you share a little bit about the program here at Mercy and why you've been working to take even more action steps in improving the trach vent patient population experience through that transition?
Sure, yeah. So Children's Mercy does have a transition to adulthood program that focuses on preparing patients to become knowledgeable about their own health care and to become strong self-advocates. And this begins as young as 12 years old. They're starting to prep them for that transition. Providers and teams work with the patients to set at least one annual goal related to transition and make sure that starting at age 12, we're giving our patients the opportunity to take charge of their health care over a long period of time so that when they do get to that 21, 22 years old age, it's not so overwhelming for them to transition out into adult care. Many of our older tracheostomy dependent patients are more than capable of learning their meds and their airway clearance and talking alone with their medical team, scheduling appointments, communicating their needs. But some of our patients are not, and we're really working with the families through that transition process and prepping them for a transition to adult care. We in our trach vent clinic are so fortunate to have a team of doctors, nurses, respiratory therapists, speech therapists who see our patients together on a regular basis. And we coordinate care with their PCPs and other specialists to make sure that we're all on track with the plan of care. However, we know that it's not often the case in adult care. So as they age out of our program, each piece of the complex puzzle that makes up their healthcare will now be handled by a different provider, often in different locations and frequently not even within the same health system, maybe not the same city. We felt that for our patients in particular, we needed to establish relationships with some adult ENT and pulmonary providers in order to assist families in navigating the world of adult care, specifically for ENT and pulmonology. The number one thing as families are getting really close to transition that we get asked is, who would my child's pulmonologist, this person I've been working with for years, or my ENT provider that I've known since my child was 2, who do they recommend that I transition to? They want to know these people that they've trusted for so long, who do they think would be a good fit? And so they're charged with the task of transitioning all of their specialists to new adult providers, and parents really want that reinforcement that they're making the right decision. So we've been working to establish contact people and referral processes at the institutions around the KC Metro, but then also out into Kansas and Missouri, because we see kids from all over both of those states and some of our other neighboring states. So our patients are really spread out, and the adult providers might be in little towns in the middle of Kansas versus here in the KC Metro. We work with other specialty clinics at Children's Mercy. So say if our kiddo is seen in the rehab clinic and cardiology clinic and by us and maybe our Beacon clinic, we'll have a conversation with those nurse coordinators or social workers to talk about, where do you foresee this kid transitioning, and maybe try to coordinate so that some of their appointments are at least at the same facility if it's a larger institution that has many specialty clinics in the same place like we do. It's helpful for families to kind of know things will all be in the same place. Yeah. And then we also work to time it so that we're all transitioning at the same time, because some kids are ready to transition at 17 and some may take all the way until they're 22 to transition. So we really talk to each other and make sure that we're doing that sort of in a coordinated manner that makes the most sense for the family. Let's see. So by ensuring that consistent timing, we feel like we're just helping to aid parents in making decisions about the new provider. We can help them set up the first visits. We can help them set up their last visits with us. We can get all their medical records to the new providers, and then ensure that we have closed the loop on outstanding issues, just equipment, supplies, all of those things, not always, but often need to transition to adult providers also, and our kids have a lot of needs. And there's, we're a work in progress. There's always going to be room for improvement. And we welcome any ideas from all of you in the GTC and any that others have on this topic. So we'd love to hear feedback after this presentation.
Awesome. Thank you so much, Jill. You've done a really good job with a lot of different work. And so we and our patients really appreciate it.
Yeah, thank you.
So now we're going to hear from Dr. Jensen, Dr. Dan Jensen. He is a pediatric ear, nose, and throat physician here at Mercy. He's been here 7 years. He led the initiative to create the pediatric trach and home vent clinic. He is a physician within that clinic. He is also the medical director of the tracheostomy program. In addition to that, he also spearheaded Children's Mercy joining the GTC after first attending a conference in 2014. So, and then he focuses on airway pathologies and tracheostomy care. So we're going to hear from him a little bit. He's going to share his perspective on the clinic and having that important patient role, patient voice in not only clinic care, but then transitioning from pediatric to adult care.
Dr. Jensen, thank you for taking time out of your busy schedule to meet with me this morning. You helped co-found our Pediatric Tracheostomy and Home Ventilation Clinic, which is a collaborative multidisciplinary clinic. Would you be willing to share from your perspective the role of the patient and family as part of that collaboration and how that role is integral in the transition from pediatric to adult care?
Sure. Well, thanks for having me join you, Emily. I have a lot of thoughts on this. I think that one of the joys of taking care of trach patients, or collaborating in their care, I should say, is getting to know our patients and their families well over time. And as part of that, as you indicated in your question, it really is a collaborative effort. Depending on the age of the child, the child's caregivers, or as they start to get older, the patient themselves, they know the patient the best. And so they know the kinds of things that tend to come up as problems on a daily or recurring basis. They know things that have been tried in the past and worked well, or maybe didn't work so well. And so as different approaches or treatments are proposed, they often have a lot of information that we don't have, or may not immediately have at our recall, to provide instant feedback about the likelihood of that approach to be successful, or to potentially cause issues that we as the providers may not anticipate. They also obviously can have a big say in our future goals and timelines for achieving those goals. Sometimes we may propose something as a goal, and the patient's caregivers or the patient themselves may say, "I want to aim higher," and we recalibrate. Or they may feel that we're shooting too fast or too slow. And that feedback is important, and it really is a collaboration as we calibrate our goals and the timeline. In terms of transition from pediatric care, which we provide, to adult care, that again is a collaborative process. We take feedback from our families in terms of timing for that transition, and also the destination, depending on where they live and their insurance and their preferences in terms of where they would like to be seen. But there's also the question of providing the relevant information to the provider who will be assuming their care after the transition. So we try hard to give as much relevant information as we can to the patient's receiving provider, so to speak, so that they'll have the information that they need to start providing care. On the other hand, just like we don't have all the information that the patient and their family have when we're making care plans, we're also never going to be able to provide all the important information. And so that also becomes a collaboration where we try to give as much as we can that's helpful, but in the end, the patient and their family are eyewitnesses to everything that's gone along. And so sometimes they, in fact, become the most important source of information for their new provider. And so I think it's worthwhile for them as they go through that transition to kind of have that mindset that my prior providers are going to do their best to provide as much information as they can, but it's also part of my role to be a solid source of information for my new provider.
Yeah, agree. Thank you so much for taking time and sharing with us today. Your role is definitely invaluable in that transition.
Thank you so much.
So Dr. Jensen is one of our ENT doctors in our collaborative multidisciplinary clinic, and Dr. Tam Williams is one of our pulmonologists that takes care of patients in that clinic. She has been here at Mercy for 5 years, and her research specialties are interstitial lung disease and severe asthma. She also is leading high fidelity simulation with Families Initiative for the tracheostomy program, and has been an integral part of collaboration for the pediatric to adult transition of trach and home ventilation patients. So she's going to speak just a minute or two here about that transition and starting the transition early and her thoughts on that.
Okay. Hi, Dr. Tam Williams. Thank you so much for agreeing to share with us today. Jill shared with us earlier a little bit about the transition program from pediatrics to adult care here at Children's Mercy, Kansas City. Would you be willing to share why you believe it's so important for our families and patients to not only know the plan for their care moving forward, but also to be an active participant in their care as they transition?
Yes, thanks, Emily. Well, for many of our patients with tracheostomies or ventilators, they and their family have been part of our Children's Mercy healthcare system for most, if not all, of their lives. So the concept of transitioning to adult care can be daunting, to say the least. Their care is not usually just with one or two specialists. It's with multiple specialists, therapists, equipment providers. They know the hospital in and out. So it's really good for families and patients to know what their present care plan is, and why their physician has chosen certain interventions or treatments, because when they go to their adult doctor, they have to be their own advocate, right? So I also tell families it's really important for them to anticipate these changes, not even from just a legal perspective of who has guardianship, etc., but also medically, to know what decision making must now be handed off to their child, well, now young adult, right? And at the same time, I encourage providers to recognize how important it is for us to start these discussions early, especially for patients who are developmentally able to participate in their own care. Some of my patients have never had to make these kinds of decisions before, simple decisions, not just difficult ones. So I like to talk about transition early and often. I also encourage families to think about this early for really practical reasons. Some of them are such as, there are interventions and treatments that are available in adult medicine that we as pediatric subspecialists do not have access to. Secondly, in our area, the wait times for adult subspecialists can be really quite long. And so I tell families, you don't want to be caught in a period of time without any provider at all. And so if you seek adult care earlier, the likelihood is higher that there will be a period of time where your care may overlap and between your pediatric provider and your adult specialist, so that you have somebody to help you if something happens before you meet with your adult person.
Wow, thank you so much for sharing your role as a provider and guiding our patients through this challenging time has been exceptional. So thank you so much for sharing with us today.
Thank you so much, Emily. Appreciate the time.
Bye.
Okay, so the last person we're going to hear from is Minette Almerslager. She is one of our parents who helped found the Patient and Family Advisory Council. She lives in Carthage, Missouri. Her husband is a pastor and they have 6 kiddos, including Bliss, who has a tracheostomy. She is currently the co-chair of our PFAC and is also a strong leader in advocacy at the, not only here at the hospital, but also in the state of Missouri. She's gone to the Capitol twice and one additional time has sent a recording to our representatives and senators in the state to have the patient voice heard. So we're going to hear from her. She's going to tell us a little bit about transitioning. Her daughter is 18. And so she is going to talk a little bit about that transition from pediatric to adult and kind of share from the patient perspective what that feels like and the role of collaboration in that.
Okay. Hi, Minette. Thank you so much for sharing with us today. You and your daughter Bliss have played an essential role in expanding the tracheostomy patient voice at Children's Mercy and throughout the state of Missouri through the PFAC. Your daughter is 18 and you are starting to prepare for the transition to adult care. Would you be willing to share how you feel about that upcoming transition?
I would. The thought of, literally the thought of Bliss and I having to leave Children's Mercy, she's been here 18 years, all 18 years, probably 45 surgeries, months and months and months and months inpatient in the PICU. So it feels about the thought of leaving Children's Mercy is on the same level as you launching me into outer space. It feels exactly the same. And I know that I speak for medically complex, fragile health families. It is terrifying. And, you know, they've graciously said that because Bliss is fresh off of so many surgeries, we have a little bit of time, but I mean, to me, it seems like an impossibility to ever get the care. We've never received the kind of care in any other medical institution that we have at Children's Mercy. You're not taken seriously. They don't know her history. They don't know, you know, here, everyone knows, has a plan in place exactly how to take care of her. But yet already, I feel like only because of the plans you guys have in place already is the only way you could even think about it. Otherwise, it is so overwhelming. It's terrifying, basically.
I know. I'm sorry. Thank you for sharing. We recognize that the transition from one set of caregivers to another comes with lots of uncertainty. As the co-chair of the PFAC and mother of a transitioning child, you have educated yourself on the transition program here at Mercy. Would you be willing to share why a program like this is so important?
Well, I don't think we would even know where to start. You know, like I said, the few times that we have gone, we do not live in the Kansas City area. We live a couple hours away, but even, you know, we live remote a little bit, and there's no place near us that if we try, just simply cannot take care of Bliss. So without Children's Mercy basically having our back, I'm not sure we would even know what direction to go at all. And so we are already getting so much reassurance that they will connect us. You can't, first of all, you can't get your foot in the door. Every adult institution is so backlogged, it's hard to even find a doctor that will, take my other adult children as patients. Who's going to take Bliss? So to be able to have that reassurance that, I feel like we're on one side of a gigantic chasm, and how do we get to that other side? And it would be insurmountable without knowing that, no, you're going to help us build the bridge to get to where Bliss needs for the proper care. And so I do feel like there would be no backbone in me without knowing that you guys are going to hold our hands and get us to the other side. So we feel very confident. There's already, a few little things that we're working on. And so it's nice to know that they will get us in touch with the right institution, the right doctors that are qualified to care for her.
Yeah. Thank you so much for sharing with us. We really appreciate it.
Well, thank you, Emily. I appreciate all you do.
Okay. So now we've heard from our providers and our patients why the patient voice is such an integral part of the healthcare process, and why having that avenue, creating that avenue within your system is so important. So I will put some contact information within the chat. Please feel free to ask questions. We have a little more time. Thank you guys so much for coming, and thank you so much for listening to our program here at Children's Mercy, and how we have instituted a venue for our families to share their voice, and I look forward to hearing from you. Thank you.
Okay. Andre, I don't see that anyone else is awake and on, so it looks like we can stop recording.